Hi everybody, and welcome to our second module on cardiovascular pharmacology. Let's start by talking about adenosine. This is the structure of adenosine shown on the slide here. And as you may know, adenosine is a nucleotide. You can find it in DNA. But we also have adenosine receptors in our body, and one place where lots of adenosine receptors are found is in the AV node. And when these receptors bind adenosine, this activates potassium channels and drives potassium out of cells. This causes the voltage across the cell to become more negative. In other words, it hyperpolarizes the cell, and as a result, AV nodal cells will take longer to depolarize when those cells have bound to adenosine. So what this means is if you administer adenosine intravenously as a drug, it will bind to adenosine receptors in the AV node and slow conduction through the AV node. Adenosine has a short half-life, so it's always given intravenously, and its main use is for the treatment of supraventricular tachycardias. In the video on ACLS and tachycardias, I talk about how the most common supraventricular tachycardia is AV nodal reentrant tachycardia, or AV-NRT. And people who develop this arrhythmia have slow and fast circuits in their AV node, so basically electricity is circling their AV node, and this is causing the heart to beat rapidly, and that can cause palpitations and other symptoms. If you administer adenosine intravenously to a patient with AV-NRT, it will slow AV nodal conduction and break this circuit. And what will happen is the arrhythmia will terminate. And I've shown an example of this on the slide. So on the left side of the tracing, this patient has a supraventricular tachycardia. After adenosine is given, AV nodal conduction slows. The arrhythmia stops at this point right here, and then we have a P wave develop, and now we've got sinus rhythm going forward. So if this patient had palpitations or some other symptoms from this SVT, adenosine would break it, cause sinus rhythm to be restored, and the patient to feel better. Adenosine also can bind receptors in the vasculature that cause vasodilation. What this means is when you administer it, patients often develop skin flushing. They can develop hypotension. Some patients even develop dyspnea and chest pain because of the vascular effects of adenosine. These will quickly resolve, but you have to warn patients before you give them adenosine for an SVT. If you ever get to do this in the emergency room, you need to warn the patient that they may briefly feel unwell, but that it will pass quickly and then the arrhythmia should be gone. And this is a picture of a man with a red face here just to remind you of the skin flushing that is very common in patients given adenosine. For your boards, you need to always remember that adenosine has a similar structure to two other compounds, theophylline, which is a drug used for COPD, and caffeine. If you look at this slide, adenosine has the base adenine, and adenine is a type of structure called a methylxanthine, and caffeine and theophylline are also methylxanthines. So these drugs, caffeine and theophylline, can block adenosine receptors. So if a patient is taking theophylline, then if you give them adenosine for an SVT, it may not work. Similarly, if a patient has consumed lots of caffeine, then the adenosine may not work. Next, let's talk about atropine. Atropine sounds a lot like adenosine, and it also works on the heart, but don't confuse the two medications. They have completely opposite effects. Atropine is a muscarinic receptor antagonist, so it blocks the effects of the parasympathetic nervous system on the heart. This is going to lead to an increased heart rate and increased conduction through the AV node. And if you understand this, it's easy to understand that atropine can be used in patients with symptomatic bradycardia because it will increase the heart rate. Because atropine also speeds conduction through the AV node, it's particularly useful in patients who have bradycardia associated with AV block. And I talk about bradycardia with AV block in more detail in the video on bradycardia. But if you look at the bottom of the screen, on the left side is an ECG from a patient who has AV block. There's a very slow heart rate, and this P wave right here is not conducted. After you administer atropine, a patient like this will have their heart rate speed up and the AV block will go away. And that's all because of the effects of atropine. It increases the rate of the sinus node firing and it increases conduction through the AV node. Atropine has many side effects and they're all related to its muscarinic blocking effects. Basically, what atropine does is shut down the parasympathetic nervous system. So all the toxicity is related to normal functions of the parasympathetic system. So for example, patients often develop dry mouth and constipation. That's because the parasympathetic system promotes oral secretions and promotes GI motility. Urinary retention is a classic side effect of atropine, especially in older men who may have prostatic hypertrophy and have trouble urinating at baseline. If you give an older man atropine, they will often develop a large distended bladder like shown in this image on the screen here. And then finally, by blocking muscarinic receptors in the brain, this can cause confusion, especially if you give atropine to elderly patients. Our next medicine is digoxin. Digoxin is a cardiac drug that has two cardiac effects. First, it can increase contractility of the left ventricle, and for this reason, it's used in patients with severe systolic heart failure who have a very low left ventricular ejection fraction. It also slows conduction through the AV node, and for this reason it can be used in patients who have atrial fibrillation to slow the ventricular rate. The way that digoxin increases contractility in cardiac myocytes is by inhibiting the sodium-potassium ATPase found in the cell membrane. If you look at this slide here, what digoxin does is block this pump here, labeled pump number 1, which normally brings potassium into myocytes and withdraws sodium from myocytes, and it uses ATP to do this, so therefore it's an ATPase. When digoxin inhibits this pump, there will be more potassium extracellularly and there will be more sodium intracellularly. In other words, sodium gets trapped inside of the cell by inhibiting pump number 1. As a result, there's less sodium exchange for calcium by pump number 2, and this causes more calcium to stay inside the cell. So the net effect of administering digoxin and inhibiting this process shown in the slide is to raise the calcium inside of myocytes, and that's what increases contractility. The way that digoxin slows conduction through the AV node has a completely separate mechanism compared to the way it increases contractility. Digoxin suppresses AV node conduction by amplifying the effects of the parasympathetic nervous system via the vagus nerve. This is a separate effect from the blockade of the sodium-potassium ATPase. Because AV node conduction is slowed by digoxin, you can use it to slow the heart rate in patients with atrial fibrillation. This won't eliminate the AFib. They'll continue to have atrial fibrillation, but fewer impulses will reach the ventricle, and that will lead to a slower heart rate. This is very similar to the way that beta blockers and calcium channel blockers slow the heart rate in atrial fibrillation, and I talk about this in the video on atrial fibrillation. Digoxin can cause toxicity if the levels in the serum get too high. First of all, digoxin is renally cleared, so there's a greater risk of toxicity in patients with chronic kidney disease. And many patients who need digoxin for heart conditions also have chronic kidney disease. You should also know that hypokalemia promotes dig toxicity, and this is super high yield to know for your boards. Let's go back to this slide. Digoxin essentially competes for a binding site with potassium. So when the potassium level gets low for any reason, more digoxin is able to bind, and that amplifies the effects of digoxin, and potentially this can lead to toxicity. Hypokalemia is caused by many diuretics, especially loop diuretics, and lots of patients who need digoxin for heart failure are also on loop diuretics. So a classic scenario that you should know for your boards is a patient taking digoxin who is started on furosemide and then develops digoxin toxicity. This occurs because the furosemide promotes hypokalemia, and the hypokalemia promotes dig toxicity. And because digoxin can be toxic at high levels, the levels often need to be monitored. You can check a serum level. The normal range is about 1 to 2 nanograms per milliliter. If you look up digoxin toxicity in a textbook, you will find many different signs and symptoms that occur in lots of different organ systems, and that's because those sodium-potassium ATPases are found all over the body. But in this slide, I've highlighted some of the key changes that you need to remember to recognize digoxin toxicity in a board question. First of all, dig toxicity classically causes GI symptoms like anorexia, nausea and vomiting, and abdominal pain. Digoxin toxicity also causes hyperkalemia. I told you before that hypokalemia can promote digoxin toxicity, but once it develops, it actually can lead to hyperkalemia. If you go back to this slide, like I told you before, digoxin and potassium compete for the same binding site. So if a patient has toxic levels of digoxin that are very high, there's less ability for potassium to bind and be taken into cardiac myocytes, and as a result, potassium can climb. So this is sometimes a point of confusion. Hypokalemia makes it more likely for digoxin toxicity to develop, but in patients who develop symptomatic digoxin toxicity, they often have hyperkalemia. There are neurologic features of digoxin toxicity. Many of these are nonspecific, like lethargy and fatigue. The classic one to know for your boards is delirium, confusion, and disorientation, especially among an elderly person. Patients can also develop weakness. Visual changes are a classic occurrence in digoxin toxicity. Some patients say that their color vision seems off. A classic complaint is seeing spots before the eyes. This is called scotomas, and then rarely it can cause blindness. And then finally, cardiac arrhythmias can develop, and I'll talk more about this in a minute. But on this slide, I've highlighted the key features to remember for dig toxicity: nausea, vomiting, confusion, and visual changes. If you see that triad of features in a patient who is taking digoxin for a heart condition, you should think that they are dig toxic. To understand the arrhythmias and the cardiac toxicity of digoxin, you need to remember what I said before, which is that digoxin leads to more sodium inside of myocytes. This raises the resting potential in atrial and ventricular myocyte cells, and this makes it easier for them to depolarize. So in patients who are dig toxic, they often have atrial or ventricular myocytes spontaneously depolarizing. This is called automaticity. And what this leads to is extra heartbeats. So PACs and PVCs, these are very, very common findings in patients who are DIG toxic. In addition, remember what I said earlier, which is that digoxin slows conduction through the AV node. So a classic finding in a patient who is DIG toxic is to have AV nodal block. So if you remember both of these things, extra beats and AV nodal block, it's easy to identify DIG toxic rhythms. On the screen, I've shown you one arrhythmia, which is a classic DIG toxic arrhythmia, so that you can recognize it if it comes up in a board question. This ECG tracing shows atrial tachycardia with AV block. If you look at the EKG, there are P waves here and here and here. The P waves are occurring at a very rapid rate of about 300 beats per minute, but those P waves are not generating a QRS complex. In other words, they're not followed by a QRS complex. That's because there's AV block. None of those P waves are conducted to the ventricle. Instead, we have a very slow rate of QRS depolarization caused by some lower pacemaker below the AV node generating the QRS complexes. So this ECG shows atrial tachycardia with AV block. There are lots of non-conducted P waves and a very slow rate of QRS generation. This is a classic DIG toxic arrhythmia. The treatment for digoxin toxicity is an antibody called Digibind that binds to digoxin and eliminates it from the body. And then in addition, you always need to check the electrolytes and correct any hyperkalemia. And this is high yield for your boards. If they describe a patient with digoxin toxicity and ask you what to do next, the answer may be to check the electrolytes to rule out hyperkalemia, because that can be life-threatening if it's not diagnosed and treated. Next, let's talk about sacubitril. Sacubitril is a drug administered to patients with systolic heart failure, and its mechanism of action is that it inhibits an enzyme called neprilysin. Neprilysin degrades atrial and brain natriuretic peptides, so when you inhibit neprilysin, you get higher levels of ANP and BNP. In patients with heart failure, there's increased activity of the renin-angiotensin-aldosterone system, or the RAS. What ANP and BNP do is counteract the RAS. They have opposite effects. So if you raise the levels of ANP and BNP, you counteract the deleterious effects of overactivation of the RAS. So some of the effects of ANP and BRP are vasodilation, natriuresis, which is excretion of sodium, also water excretion, which is diuresis, and reduced sympathetic tone. And all of these things are the opposite of what the renin-angiotensin-aldosterone system does. So by raising these levels with sacubitril, you boost these effects, and that's beneficial in patients with heart failure. Sacubitril is never administered alone. It's always administered as a combination medicine called Entresto. Entresto is an oral medication, and it's a combination of sacubitril and valsartan. Valsartan is an angiotensin receptor blocker, or ARB. I'll talk about ARBs later in this video, but what ARBs do is they block the activity of the RAS. So the idea here is that the combination drug Entresto will decrease the activity of the RAS through the valsartan component and increase the activity of ANP and BNP through the sacubitril component. And this combination of effects is overall favorable for patients with heart failure. And in a large clinical study, Entresto was shown to lower the mortality rate from systolic heart failure and also lower the hospitalization rate for systolic heart failure. So this is why we administer this drug. Sacubitril has only been studied in combination with valsartan as the drug Entresto, and in trials of Entresto, many of the side effects were similar to those of other ARBs. These are things like hypotension and hyperkalemia. There's a special side effect of sacubitril when you give it as Entresto that you need to know about for your boards, however, and that's angioedema. Angioedema is tissue swelling, and it can involve the tongue and the larynx and potentially be life-threatening. This is a rare, feared adverse effect of giving someone Entresto, which contains valsartan and sacubitril. The cause of the angioedema is elevated bradykinin levels, and this occurs because neprilysin normally degrades bradykinin. So when you inhibit neprilysin with sacubitril, you can boost the levels of bradykinin, and that can potentially cause angioedema. What this means clinically is that you can never give sacubitril together with ACE inhibitors, and this is the super high yield point for your boards. ACE inhibitors also raise the level of bradykinin, so if you give an ACE inhibitor together with sacubitril as part of Entresto, that can cause angioedema. So in any patient in whom you're going to prescribe Entresto for heart failure, if they are on an ACE inhibitor, you need to stop the drug and wait 48 hours before giving Entresto. If they aren't on an ACE inhibitor, you can start Entresto right away, but you should never co-administer an ACE inhibitor. And this is super high yield. This is the kind of thing that comes up on lots of board exams. Next drug we'll talk about is ivabradine. Ivabradine is also given to patients with systolic heart failure, and the way it works is by inhibiting the sinus node. This will slow the heart rate. The idea behind ivabradine is that patients who have systolic heart failure and a fast heart rate have a worse prognosis. Now, we usually use beta blockers to slow the heart rate because beta blockers are associated with improved survival in heart failure. But there are some patients who can't tolerate the beta blockers because beta blockers reduce contractility in addition to heart rate. So ivabradine has a unique mechanism of action that slows the heart rate without decreasing contractility. The way it does this is by inhibiting the pacemaker action potential in the sinus node. This is called the funny current. If you look at this drawing on the top right side of the screen here, this is a drawing of the action potential in the sinus node. Phase 4 of this action potential is called the funny current. It involves the slow movement of sodium ions outside of SA nodal cells. This causes the voltage to slowly increase and then eventually depolarization occurs. So if you inhibit the funny current, it takes longer for this cell to reach threshold and depolarize, and therefore the SA node depolarizes at a slower rate, and that lowers the heart rate. This has no effect on contractility the way that beta blockers do. So we usually use ivabradine only in patients who are maxed out on their beta blocker but still have a high heart rate. There is some limited evidence from clinical trials that in appropriate patients, ivabradine can reduce the mortality from systolic heart failure and also reduce the hospitalization rate. The side effects are usually related to too much slowing of the heart rate, so patients can develop bradycardia and hypotension and syncope. But there's one special side effect you should know. About 15% of patients on ivabradine experience what are called phosphenes. These are visual disturbances where patients see these rings or spots of bright light. This is a very unusual side effect, but it's relatively common in patients taking ivabradine. Moving on, let's talk about ranolazine. Ranolazine is a drug used in rare patients who have refractory angina. So in a board question, this is going to be a patient who has exertional chest pain that cannot be relieved with angioplasty or bypass surgery or other drugs. The way ranolazine works is that it inhibits the late sodium current into cardiac myocytes. If you look at the right side of the screen, this is the action potential for a cardiac myocyte. And at phase 0, when the cells depolarize, sodium rushes into the cell. That's the early sodium current. But during the plateau phase here, there's also some sodium influx into cardiac myocytes, and that's what is inhibited by ranolazine. When this influx of sodium is inhibited, there will be less sodium inside of the cell. As a result, there will be less activity of this sodium-calcium exchanger. The net result is that therefore there will be less calcium inside of cells. That's going to slightly reduce the contractility, and it decreases the wall tension. The idea here is that when you have lots of calcium in myocytes, there's more contractility, more wall tension, and more oxygen demand. So by inhibiting sodium influx, you decrease calcium in cells and you lower the oxygen demand. So in patients with refractory angina, this can sometimes help by restoring balance in a situation of supply-demand mismatch of oxygen. The one side effect of this you should know about for your boards is it can prolong the QT interval. I've shown this at the bottom of the screen here. Drugs which change the cardiac action potential from the blue line here to the red line here will prolong the QT interval, which is from the QRS complex beginning to the end of the T wave here, and that puts patients at risk for torsade de pointes, a life-threatening cardiac arrhythmia. Next, let's talk about nitrates. Nitrates are drugs used to treat stable angina. Remember, in patients with stable angina, there is a narrowing of a coronary artery which decreases the supply of oxygen, so there's a decreased supply, and therefore the supply is less than the oxygen demand. So what nitrates do is they lower the oxygen demand so that once again supply and demand will be matched. The predominant way that nitrates do this is through venous dilation. When you dilate the veins, they become bigger and they hold more blood, and this pools blood in the venous system and takes it away from the left ventricle. This is referred to as lowering the left ventricular preload. And when you lower the preload, you lower the work that the heart has to do. That's less oxygen demand, and therefore the supply and demand will be matched. In addition to venous dilation, nitrates also cause some degree of arterial vasodilation. Usually the veins dilate much more than the arteries, but there's a little bit of arterial dilation. This can increase coronary perfusion, and also some peripheral vasodilation occurs, which lowers the afterload. So these effects also contribute to the way that nitrates balance oxygen supply and demand in patients who have stable angina. To understand the physiologic response to nitrates, you need to appreciate that they drop the preload, which is going to decrease the cardiac output. And this in turn is going to activate the sympathetic nervous system. And when the activity of the sympathetic nervous system increases, the heart rate and the contractility of the left ventricle will go up. This increases oxygen demand, which is the opposite of what we want to do for angina. So although nitrates are good because they reduce the preload and reduce the oxygen demand of the heart, they can be bad for patients with angina because of these sympathetic nervous system activating effects. So for this reason, we usually administer nitrates together with a beta blocker or a calcium channel blocker, because this blunts the reflex effect of sympathetic nervous system activation. This will allow the patient to have all the beneficial effects of nitrates and none of the negative effects from sympathetic nervous system activation. The most common side effect of nitrates is a headache. This is because there is meningeal vasodilation. Some patients develop flushing from increased blood flow to the skin from that peripheral vasodilation. And then if you give too much of a nitrate, patients can become hypotensive and faint. It's super high yield to know about nitrates and erectile dysfunction. So many men who have coronary artery disease also have erectile dysfunction. And many of these men are prescribed sildenafil as a treatment for erectile dysfunction. If you give sildenafil together with nitrates, these men can develop life-threatening hypotension. So erectile dysfunction drugs like sildenafil are contraindicated in men taking nitrates. Super high yield. This comes up on lots of board exams. Let's talk about spironolactone and eplerenone. These drugs are potassium-sparing diuretics. They get this name because they are diuretics, meaning they increase sodium and water excretion, but they spare potassium, which means unlike other diuretics, they do not increase potassium excretion. So with loop diuretics like furosemide and torsemide, the main feared outcome in terms of electrolytes is hypokalemia. But with drugs like spironolactone and eplerenone, they spare potassium, so in this case, hyperkalemia is a side effect. And hyperkalemia can be life-threatening. It can cause arrhythmias. So there's a take-home point here in terms of your board exams. In any patient in whom you are going to prescribe one of these drugs, you have to check the BUN and creatinine and potassium before starting the drug, and then you have to check it again after they've been on the drug for about a week or so. This is super high yield to know. This is something we always do, and the reason is because hyperkalemia is so dangerous. Spironolactone and eplerenone are prescribed to patients with chronic systolic heart failure, and the reason is because in large clinical trials, patients who take these drugs have been shown to have a reduced mortality from heart failure and a reduced hospitalization rate. Spironolactone structure is shown at the bottom left side of the screen here, and you can see that it has a similar structure to testosterone. So for this reason, it blocks testosterone effects, and men who take spironolactone can develop gynecomastia through this mechanism. Eplerenone's claim to fame is that it's chemically modified so that it does not interfere with testosterone metabolism. So men who take eplerenone do not get gynecomastia. And the main time that we use eplerenone is in a man who was originally started on spironolactone but developed breast enlargement or breast tenderness. We then switch that patient to eplerenone. You should also know that both of these drugs are derivatives of progesterone, and therefore they can activate progesterone receptors, and in women this can potentially cause amenorrhea. Luckily, most patients with chronic systolic heart failure are older. Most of the women are postmenopausal, so this is not a major issue. I'll finish this video by briefly discussing ACE inhibitors and ARBs. So by way of brief review, the way that the renin-angiotensin-aldosterone system works is that renin is produced by the kidneys. Renin converts angiotensinogen, which is produced by the liver, into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 by the enzyme angiotensin converting enzyme, otherwise known as ACE. And angiotensin 2 is what exerts all the clinical effects. So the way that ACE inhibitors work is they blunt the ACE enzyme. The way that ARBs work is they block the binding of angiotensin 2 to its receptors. ACE inhibitors have names that all end in pril, like captopril, enalapril, lisinopril, or ramipril. And as I just mentioned, they block the conversion of A1 to A2. Angiotensin receptor blockers all have names that end in sartan, like candesartan, irbesartan, or valsartan, and they directly block the A2 receptor. And both of these classes of drugs have been shown to reduce mortality and reduce hospitalizations in patients with chronic systolic heart failure. That's the main reason why we use these drugs in cardiology. They can also be used to lower the blood pressure in patients who have hypertension. The side effects are hyperkalemia. That's because they block the effects of aldosterone. One of the things that angiotensin does is promote the release of aldosterone from the adrenal glands. So when you block the effects of A2, there will be a decrease in aldo levels. Also, because these drugs decrease the levels of angiotensin 2, that can decrease the glomerular filtration rate, so potentially these drugs can precipitate renal failure. Besides those side effects that are common to both drug classes, ACE inhibitors have two unique side effects you need to know about. Both of these are related to bradykinin. As I told you before, ACE inhibitors boost the level of bradykinin because normally ACE breaks down bradykinin. This can cause a dry cough. About 10% of patients taking ACE inhibitors develop a dry cough from the drug. If you switch those patients to an ARB, they will not have the cough. Second side effect is more rare but more dangerous, angioedema, which I told you before is swelling of the face and tongue. This is a picture of a child with angioedema involving the area around the eye. When it involves the tongue or the larynx, it can lead to asphyxiation and become life-threatening. And in patients on ACE inhibitors who develop angioedema, you have to stop the drug. Angioedema is much less common with ARBs, although it has been reported. And that concludes our second video on cardiac pharmacology.